The American Rehabilitation Educational Network presents Clinical Update, dedicated to meeting the continuing education needs of rehabilitation and healthcare professionals. Clinical Update is a growing series of informative, useful videotape excerpts from Aaron's monthly video conferences. Applying the talents and expertise of distinguished faculty members from around the world, these programs are specifically designed to provide concise, clinically accurate knowledge for use within the daily practice of physical therapists, occupational therapists, nurses, psychologists, speech pathologists, physicians, and other healthcare professionals. This program, Physical Therapy and the Geriatric Patient, features Dr. Carol Bernstein-Lewis.
Carol, you've of course done extensive work with older patients. What do you see as the key components in a physical therapy evaluation of an older patient?
Well, in the handbook on page 6, I've identified 6 components that I like to stress in an evaluation. Now, this is not necessarily a form, but things that I look at myself when I work with an older patient.
Okay.
Number 1 is function, and I try to stress that as much as I possibly can, looking at what the person can do. I start off with questions like, well, what do you want to do that you can't do, or what are you having problems with or difficulty, really trying to get them to hone in on what specifically they're coming to physical therapy for. Then I do what I call a body systems check for myself to make sure that I'm not keying in on what the diagnosis is. You know, I may get a diagnosis for osteoarthritis of the knee, and all of a sudden everything's looking at the range of motion in the knee, the mobility of the joint, the muscle structure, and I forget all the other things. So what I try to say to myself, just like when you read an x-ray, if you don't have a form for looking at an x-ray, you're not going to know what you're looking at. So I say to myself, what physiological changes am I looking at? Does this person have decreased strength, sensory problems? And then I switch into the psychosocial realm. Are there other things going on in the person's life? Have they recently retired? Is there a death of a spouse? Are they having trouble because their family doesn't visit them anymore? And then I check into the difference between disease and normal aging. The fact that, well, you know, they may well have arthritis of the knee, but on top of that, they could be deconditioned. They may have some other problems that are contributing to that. So I go through that in my mind. Then I ask them their expectations. You know, what do they want? Are they realistic? Are they unrealistic? You have patients that want to run a marathon, and then you'll have patients that say to you, well, I don't want very much. All I really want to do is, you know, just feel a little bit better. So, you know, what is it they want to do? And if you can get it in objective terms, like, for the example, the one we're going to see, I just want to be able to tie my clothes in the back, or fasten my bra, or put on my shoes, something real objective, then you could begin to work for that, and maybe she's shooting too low. But in reality, you know what they want and how hard you can push them, and if they have some realistic ideas.
What if a patient is shooting too high? What if a patient says, you know, I want to run a marathon, and you think that's really not possible? Do you discuss that immediately up front with the patient?
Well, this is my way of doing it. I always like hope. You know, I always like the idea that there always is some hope. So what I like to do is work incrementally and say, well, we'll make that a long-term goal, all right? And let's work for shorter-term goals. And then let's reassess and see if that long-term goal really is realistic. Mm-hmm. And you'd be surprised.
Are you surprised sometimes?
I haven't had a marathon runner yet, but I have been surprised at some of the things that my patients are doing. They've been running in some of the races that we just saw. And it's amazing, you know, just a little bit of encouragement, because sometimes we have such myths in our mind about what aging is.
Yeah.
And you need to change that. Then I go on to support systems, and I think that's often ignored. You can use it in many ways as far as expectations for help in a home program, or what they actually need to do to be independent if they have other people around to help them out. Then I look at home programs, and I keep in mind right from the very first question as to how am I going to get this person to do their exercises at home, or I use home programs to also mean in their rooms, if it's in a long-term care facility. You know, what can they do when they're not seeing me? And that's important, because then you begin to combat the adverse effects of hypokinetics, which is decreased activity, and that's a tremendous problem. So getting that from the very beginning and reinforcing it all the way through is extremely important. And finally, I look at the environment. You can't make somebody functionally independent if you don't know where they're going to be independent. You know, you may well get them walking without any type of assistive device, but then you go to their home and you look down and you see they have brown chairs and a brown coffee table and a brown rug, and you know, you wonder to yourself, how many times does that person trip over that coffee table because they can't see it? There's no good color contrasting. Are there things in the environment that they can use to actually help themselves that they haven't even thought of? And so often we take for granted all the knowledge that we have, and somebody else is just delighted to hear some very helpful suggestions.
Nice practical clues. Yeah, what I'd like to do is go back and talk in some depth about each one of these 6 components of a physical therapy evaluation. Let's start at the beginning. How do you incorporate functional emphasis into your evaluation?
Okay, I do it several ways. I think the easiest is I ask them what they can or can't do, and then I watch them. Oftentimes they will tell you one thing and then they will do another. So if someone says I can get out of a chair, I have difficulty getting out of a chair. Part of it may well be balance, or it may be weakness in the extensor muscles of the thigh, or it could just be a problem with knowing how to place their body so they're getting the best advantage of getting out of the chair. So I break up the task at its various points to see how they are actually performing it. And that's one good way. You can do it with almost anything. You know, the fact that they can't tie their robe and you ask them to do it. They may well have problems with fine motor coordination. It's not their shoulder limitation at all. So asking and watching I find very helpful.
Now, you have other techniques, though, that you use to obtain this kind of functional information. I'm thinking of functional ambulation in particular, because this chart is interesting.
Yeah. Well, first let me just mention, I also use and I've developed it myself. It's a functional evaluation form. And I say I didn't put it in there because I think anybody could do it. I just write down what are functional problems. I mean, let's face it, the patients we see, they may have several diagnoses, but their problems are functional, like Dr. Lee said. So I note weakness, I note endurance problems, sensory problems, pain, incontinence, all the things that functionally can limit the patient. And then I know what is causing that. Instead of looking at range of motion and manual muscle strength, which I think are components of the actual functional problem, I think starting to address the problem along that lines gives us a better idea of how to functionally treat our patients. So I do that. And then one form I like to use, and the functional ambulation profile is on page 9. I like it. It was developed by Dr. Roger Nelson, and he did this particular profile back in the 1970s, and he validated it on patients that had cerebrovascular accidents. Very simple to do. You can use it 10, 12 times with your patients, and I'll go through it with you. First you put in the date, and then you have the patient, all you need is a stopwatch and a patient, really. You look at their bilateral time, how long they can stand on each leg, and the optimal time is 2 minutes. You can spend longer than that, but then you'll spend longer in your test, and it usually takes about 7 minutes to do it. Then you see how long they can stand on one leg. All right, now in these shoes, I'm taking a rider. I don't always wear shoes like this. I don't want any calls about my shoes, okay? No, physical therapists do that. Anyway, you see how long they can stand on one leg, all right? And what I do is I offer them my hands for balance, but not for weight bearing, so that you can see how well they can do that. Now, in this test, it's very easy. You can also test for balance. Have them stand up, give them a little push. Now, you know if you give a little patient a push and it takes 30 seconds for them to come back, they definitely have a balance problem, and you may want to note that down in comments. See how well they recover. That I put down in comments. But then have them stand on the right leg. Again, you're going to do a stopwatch, see how long they can do it. Then you do time to complete 8 steps or 4 transfers, and you ask them as quickly as possible to take 8 steps, and you're going to see that in the film. But it's 1, 2, 3, 4, 5, 6, 7, 8. Just how quickly they can transfer weight. The next part, and I'll sit down for this. The next part of walking or dynamic transfer of weight through actual
space,
through space is the last part. And I made a mistake on the form, but what you do is you can do it in a parallel bars. I don't ever do it in parallel bars because in most facilities or in someone's house you don't have parallel bars, and that's not how normal people walk. So I just cut off a space, whether it be 12 feet, 16 feet, whatever is functional. How far it is to get to the kitchen, for example, might be the distance you decide to use. So I time them with a stopwatch, and what you write down in the square is how long it took them to go that distance and how many steps it took. So usually I slash that line and put down number of steps. So let's say it's 14 steps. As the person begins to improve, what you will see is a shorter period of time. Let's say for this lady, 18 seconds, and she did improve. And I should have put her improved numbers down here, and the number of steps. And her steps got bigger, which meant she was using energy more effectively.
A much better stride.
Exactly, when she was walking. So it's a nice way of documenting when your patients are improving. And then down in the comments section, you could put things like the type of assistive device they're using. You can do a gait evaluation. As they walk to you, you may just want to count the steps and write down the time. As they walk back, you can note lack of shoulder rotation, left hip appears higher than right hip, excessive steppage gait, whatever it is that you want to put down there can go in the comments section. And oftentimes we may be rushed for time. I like this because it's a quick form that can be done in less than 7 minutes, and it's quantifiable.
Yes, and even if the gains are small, if they're there, that's a way to show the patient that there are indeed gains being made, and I would think that would be a motivator.
Oh, definitely.
Continuing with therapy, yeah. And so this example that you just talked us through was completed actually for a patient at your physical therapy services in Washington, and we do have a videotape of part of your assessment of this same woman. Is there anything that you'd like to tell us about her before we take a look at the tape?
Yes. She's a delightful lady. She had a stroke in 1982. She had a myocardial infarction in 1984. She has concurrent diagnoses of epilepsy, depression, and diabetes mellitus. So, I don't think she's that unusual a patient. I think most of your patients have that kind of problem list. And she came in essentially for a shoulder problem. And as we began to work with her, I found out the reason she wasn't independent was because she also had balance problems. She also had some unresolved problems from her CVA. I do want to mention that what we actually filmed was done sort of partway through her treatment program. And you'll see she has very good shoulder motion by that time.
But she did not.
She did not initially. So there's a little bit of discrepancy there.
Okay. All right, with that as background, then let's take a look at the tape.
Haynes?
Hello.
How are you doing?
Oh, better, much better.
Okay, I'm going to ask you a couple questions. Very similar that I do each time I see you, but the very first time I saw you, I spent the initial evaluation time getting all kinds of information on what's been happening. So let me ask you just a couple things. You're coming here mainly for what? What is your biggest problem, would you say?
A pain in the shoulder.
In the shoulder, okay. And how long have you had that?
Only since June.
Since June. Now tell me what happened in June.
A heart attack.
Okay, you had a heart
At
attack.
the latter part of the month. The pain developed after that.
In your left shoulder?
In the left shoulder.
Okay.
No pain like I've ever had before.
And when you talked to your doctor, what did he say about the pain in your shoulder?
He said it was not unusual for previous stroke patients to have such pain.
Okay. Okay, let me ask you, what kind of things can't you do because of your shoulder?
I can't reach up to do anything with my arm.
Okay.
I can't put my clothing on properly.
Okay.
Certainly I can't fasten any clothing in the back.
Okay.
Can't lift anything, and can't carry anything with any weight to it.
Let me ask you one more question before I have you change and we can check out your motion and how you're walking. I would like to know what your expectations are, what you'd like to happen when you're done with physical therapy.
I would just like to be able to walk normal so that I wouldn't look like a little old lady.
Okay. And what about you with your arm? Any?
With my arm, if I could tie the nightgown,
Okay.
I would be very happy.
Okay. Okay, great. I would like you to move your head side to side. Like bring your ear to your shoulder. Good. Keep your shoulder down, just your head. Okay, and then back up, and then keep your head symmetrical and just tilt gently to one side and then to the other. Now tell me, way over, how does that feel?
It has a tendency to make me dizzy.
Okay.
Then
Oh, that's important too.
Yeah.
Go ahead. Okay, now you're obviously showing me some limitations there. Can you do it again? Let me just show you. The motion that I want you to do is this. Okay, I don't want you to turn, but I want you to pretty much keep your head in line and just bring your ear to your shoulder without bringing your shoulder up. All right, you try it. Good. Again, pretty symmetrical. There you go. And then the other way. There you go. Which side hurts more that you go to?
Again, the left.
Okay. It hurts more when you go to the left?
Yeah.
And does it hurt on the left side when you go to the left?
Yeah.
Okay. We're looking at the motion in your scapula. Okay? Straight up. Real nice. As far as you can. Let me know if you're hurting at all. Okay? Good. And back down. There you go. Okay, hold. Don't let me push them up, okay? Good. Okay, and don't let me relax. Don't let me push him in. Okay, that bother you at all?
No.
No? Okay, relax, relax, relax. Hold him out to the side like that. There you go. Hold strong. Okay. Yeah.
Yeah,
that one hurt?
Yeah, the left
Okay.
one.
And then straight forward. Straight forward. Hold him right there. Don't let me push him down. Okay. Oh, hold again. Okay. And then I want you to pull back like, you know, you're doing a cheer or something. Okay, hold strong. Good. And hold strong. Okay. Any pain?
No.
Okay, relax. All right, let me take a look. Now I'm just going to poke around a little bit. Is any of that tender? Or in front here?
More in front.
Okay, turn around. Let me just poke on the front side, okay? Right there. Any of that? Okay. How about in around there?
Now you hit it right there.
Right there? Okay. All right, I'm going to move your shoulder around a little bit, all right? And I want to see how it moves and all that. Why don't you bring your arm straight back in the air, as far as you can. Go ahead. As far as you can. Excellent. Real good. Does it hurt at all?
It's beginning to hurt now, right?
Right under there. Okay, good. Now let's come on down. All right, and let's move it out here. Good. Move it out here, and then I want you to bring your hand down, like you're going to touch the bed.
Yeah,
Good. Okay, and then come back this way, as far as you can. Good. Good. Okay. I'm going to move you this time, okay? Let's go way back. Good. That's it. Good. That's it. Keep going. Nice. All right. Now let's go out like this. Good. Good. Okay, now just relax. I'm just gently going to pull on your shoulder. Okay? Oh, you got to relax. There you go. Just relax. Oh, relax. Don't fight me back. Just kind of relax. I just want to check the motion in the joint, okay? Good. And let me know if anything I do hurt you. Good. Oh, that's excellent. Really stretch. Really stretch. That's it. Use the thumb as your guide and reach way out. Reach way out. Go. Go, go, go. Way out. Yeah.
Hold it there.
Way out. Good. Come on, deep breath. And as you blow out, stretch back. Just let your arm relax. Good. Very nice. Okay, bring it on up. Very nice.
Yeah.
Okay, so could you turn over that way a little bit? There we go. And I want you to lift your arm. Put your arm straight over here. Okay, and I want you to lift it straight back in the air. Straight as you can. Go ahead, as far back as you can. Way back. Good. Keep going as far as you can. Nice work. Good, good, good. And back down. That hurt?
Yes, that hurt.
Okay. I'm gonna do a little pulling with you, okay? We're gonna do that reaching again. Like you were reaching for my hand way up here. Reach way up. Come on. Up, up, up. Okay, now reach way over your head over here. Come on, keep going. Up, 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 up. Way back. Way out. Reach out as far as you can. Oh, that's good. That's just excellent. Good, 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 good. And relax. Now, what I want you to do is take 8 steps as quickly as you can. Watch me. You're going to do 1, 2, 3, 4, 5, 6, 7, 8. Okay, just as fast as you can. Ready, get set, go. Great. That's it. Very good. Okay, now what I'm going to have you do is just walk a distance towards me. All right, as quickly as you can. And I'm just going to time you and see how many steps you take. So stay there, and when I say go, I want you to walk towards me. All right? On your mark, get set, go. Very good, very good. Now let me have you walk back also. Good, and take your time, just walk like you always walk. Good, good, good.
Okay, tell us some more about that assessment, why you were doing some of the kinds of things you were doing. I noticed the attention to the neck area, for instance.
First of all, let me just point out, it is a screening assessment, which is what I like to do. And then when I find areas that need work, then you go deeper.
Right.
I was obviously not doing a manual muscle test for several reasons. I don't do that. Position of function, oftentimes our manual muscle tests aren't in position of function, and because of dysfunctional motions that older patients have. For example, Florence Kendall talks about it, the stretch weakness that they may well have, and if you try and do a manual muscle test in an elongated position, you won't be getting the optimum. Marilyn Gossman wrote an article, 1983, in the PT Journal about that, excellent article, very relevant to the elderly population. So why are we doing that? Why waste our time? I was using a real general Cyriax, kind of active range of motion, clear the neck for the shoulder, because oftentimes what you see in an older person is one or two problems that may overlay themselves. They may have osteoarthritis and rheumatoid arthritis. They could have a spur. All kinds of things can complicate that. So if you do a general screening, you may be able to pick up other problems that may be contributing to what the problem really is. So I like to do that. I find an area that really needs the work, and then I work on that. And in doing my evaluation, I'm almost planning my treatment program while I'm doing it. I'm looking for ways of working with that person, planning a home program. So that's the type of thing I was doing with her. I did want to mention that I was doing both her lower extremities and upper extremities, and it is a much longer eval than that.
Sure,
but
that
those
was
are
just
some
an
highlights.
excerpt, yeah. Let's talk about what you look at in a patient's gait, for instance, in a general assessment, because that's so important.
Yeah, I do look at some other musculoskeletal and gait considerations. Posture, I think, is extremely important. When I see some older patients' posture, and recently I've had some patients that have really hit home because of the forward head and the rounding shoulders. It's probably one of the worst things you can have for someone who has a possibility of having a vertebral compression fracture due to osteoporosis. All that forward force on the vertebra, where you have much thinner trabeculi, really can cause vertebral compression fractures so easily. So if you begin to work with your patients on bringing their bodies back, their head into chin tucks, their shoulders back into some retraction, it's very beneficial. So I do check that out with almost all my patients and suggest that they do that. In addition, I look at the gait, and on page 8 I have some gait changes noted in the elderly, and I just want to mention some of them and mention basically what gait is. Gait is a loss and recovery of balance, and we use inertia. And it's unfortunate that the older patient gets into what's called a catch-22, where they don't quite have enough strength, and yet you're calling on them to use more strength to improve their gait. But once they're able to do that, they can have a much stronger gait. So what I do is I notice some of the things that might help them get a little bit more energy. The fact that they have stiffness greater proximally than distally, in other words, in the shoulders and in the hips versus the feet and the hands and the arms. They have less automatic movements, and I'm going to just kind of show you some of these. When I say automatic movements, I'm talking about things like arm swing. When you have arm swing, you can help pull yourself along. In addition to that, there's the length of the stride, and that's not in the handout, so I want to mention that. They take shorter steps, and if you're a runner, that you want to take nice long steps, because then you actually use inertia better. They have a broader stride width. In other words, their stride is farther apart, mostly for balance.
Sure.
And they have what's called a decreased heel floor angle. It's hard to show in these shoes, but aren't they nice? No. What you do is you try to bend your ankle so that you don't have to do a steppage gait. If you can just swing your leg straight through and dorsiflex your ankle, you're going to get a much better gait. But that adds to a couple things. The fact that the person may have less dorsiflexion, so if you can just stretch out the plantar flexors, they'll be able to move easier. In addition, they can have weak plantar flexors, so they're not getting as good a push-off, and they're pulling in the hip flexors, the knee flexors to get...
Try to make up, yeah.
And plantar flexors are also important in balance. If a person stands there, remember sailors, the vision you have of sailors keeping their balance on ship, they use those plantar flexors. And when my patients have balance problems, I check it out, and oftentimes they can't do the manual muscle test for their plantar flexors because they're too weak. So I have them work on toe-ups and the heel cord stretch, very similar to what the runners do, to work on strengthening those areas. In addition, there's less rotation of the hips and shoulders, and that also helps the inertia. getting the rotation in there. And you may find very stiff trunks and stiff hips, but we're going to do some exercises later to work on that.
Sounds good. Okay. Now, I know you also asked your patients about their medications in your evaluations. Did you, for instance, adjust your treatment of the patient whom we just saw because of medications?
Yeah, that's important, especially if they're taking medications that make them drowsy, or in her case, she was taking antihypertensive medications. So when I give her a home program, one important consideration is looking at if she becomes hypotensive. Does she actually get dizzy when she sits up quickly? And that happens. You have to be careful with your patients who are taking heart medications. If you're teaching them how to monitor themselves by taking their heart rate and their medication actually doesn't let them get a higher heart rate, well, that's inappropriate too.
Sure.
There's a lot of medications that cause lethargy, may make them very tired. Fatigue is such an important factor in an exercise program. I use it two ways. If my patients call up and say, I'm too tired to come in, often they're telling me that they're too depressed to come in, and exercise is going to make them feel better. So I try and encourage them to come in. If, on the other hand, they're tired and lethargic and fatigued afterwards, that could be a cardiovascular sign that they're not using their reserve volume, that they've overused, and they need to slow down what they're doing. And you'd be surprised that very little exercise for certain deconditioned people is enough to cause that kind of response.
Yeah. Let's talk about expectations. Clearly, you think it's important to know what a patient expects from physical therapy. Do you find that most patients' expectations are realistic, or do you have to do a lot of guidance?
Well, I think it's kind of sad to say, but I think it's often our expectations that we're putting on our patients. It's so much better to hear what they want to do and then design your treatment around that. If what they want to do is be able to clean out a cabinet that they haven't cleaned in 6 months, that may be the thing that we're going to work for, the way we're going to design our program to fit that need.
So you think sometimes we misdesign a program because we're trying to line somebody up like a textbook instead of helping them do what they want to do? Okay. And you mentioned determining what the patient's support system situation is. How do you use that information specifically? Can you give us a couple of examples?
Sure. For example, if somebody is going to be doing a home program, what I like to do is either see who is there to help them. Now, this lady doesn't have a support system. She doesn't have family. She has people that come in maybe once or twice a week to check on her. So that's not a good support system. What I get her to do is, what I would get a family to do would be to have them help with the exercise program, guide the exercise program, be a motivator to keep them going in an exercise program. On the other hand, an important aspect of a support system is goal setting. Am I trying to get them totally independent like this lady? She didn't have anybody to come in and help her, so essentially she had to be independent by herself. Whereas if someone has a very supportive spouse who's going to help them with dressing or be there if they have balance problems, I may change my goal somewhat, if that's realistic.
You just mentioned home programs. I know that you greatly emphasize home programs for your patients. What, especially for this older population that we're talking about today, are the advantages, do you think, of a home program?
Well, some of the changes that occur with age, for example, flexibility, strength changes, especially flexibility, is that it's just slower. One of the considerations in treating a flexibility problem due to collagenous adhesions is that it's a slower process. So therefore, if let's say I don't get reimbursed after a certain period of time, if I know my patient has a good home program, that they may come back 6 months down the road and say, hey, I'm doing great, and they're now able to do all those things that they originally wanted to do, and I've got them started. So I take a home program from the very beginning, teach it the very first day, and then follow it through subsequently.
Okay.
That's interesting.
And you've also mentioned that environment is a key component of your evaluation. What in particular are you looking for? You mentioned one example with the brown coffee table on the brown rug on the dark wood floor. What other kinds of things?
Okay, one thing I like is in the handout, page 22 and 24 and 25 are things that I use on a daily basis with my patients. Page 22 is from the National Council on Aging's video cassette, The Sixth Sense, and they identify various areas where you can help somebody out in a sensory environment, looking at lighting, colors, lettering, how we're talking to the people we're working with, kind of to check us out, to check the family out, touch, making sure there's enough stimulation for the person in the realm of the tactile sense.
Sure.
And then really the most important part is checking dangerous areas, making
Yeah.
sure the person is safe. Then on page 20...
Can I ask you something before we turn the page? Under colors, a lot of the things, that the reasoning for them is logically obvious, but there's a question, are the predominant colors red, orange, pink, and yellow? Why would you want to know that?
Well, they could be too much of a stimulus.
Okay.
And you want to make sure
Okay.
that colors are restful and color contrast to themselves, but not too much. There was kind of in vogue to stimulate the older person.
Yeah.
And for some
Estee
people,
Lauder colors.
Yeah. For some people, that's too much. If you get somebody who has
Okay.
a slight brain syndrome and they're a little bit confused, it might be too much stimulation. In our clinic, we have one room that's very quiet, very calm colors, so that when you're talking to someone, they're not distracted by all the things that are around them.
Okay.
So that's another one. You want to make sure your colors really do contrast well. Pills tend to be pink and beige and white, and they all look very similar. Nobody wants to take a big green pill. We all want to take little innocuous pills. So that's one area. On the other page are just different ways of compensating for visual problems and hearing problems. And I like it because it lets you know what you can do to make the environment easier for the older person that you're
Yes.
working with and to make your program more effective.
Okay, so for visual and hearing problems, then we have pages of hints. That's enormously helpful. Okay, now it's clear that you advocate a holistic, a comprehensive evaluation. Let's move on to treatment then. What concepts do you think are important for treating dysfunctions in older adults?
I like to use very different programs for each person. As a matter of fact, some of my patients make the comment that they never know what to expect when they come in, because the one thing I will always do is reinforce their home program. That's always one part of their program, and you'll see in the videotape of the treatment, I'm having this lady lift a weight. At home, she uses pinto beans. So it's something that she can carry over to what I'm doing in the clinic. On the other hand, I like to use equipment. I like to use modern equipment because you can get realistic feedback from it. We are in a high-tech environment, and I think so often we're afraid to hook older people into some of the high technology that's out there. My patients love it. This one lady was real excited because she said she saw the UBE on one of the movies that she went to, and she said, "Hey, I work out on that." Her and the Russian in Rocky IV. But it's kind of it's diverse, it's individual. They can get reaching motions on various pieces of equipment, and
Exactly.
it's a nice way of integrating the home program with your clinical work.
And you plan your treatment program, it flows right from your evaluation so that it's in parallel with your evaluation,
Yes,
is it not?
yes.
So it's functionally oriented.
Exactly.
Yeah, rotation for the sake of rotation is not what you're after. Yeah.
Exactly.
We do have a tape of you treating the patient that we just saw you evaluate. Would you like us to watch for anything in particular?
I think what's important is to look for the diversity of the program and the fact that, again, I reinforced the home program with her.
Okay, and the functional focus is something
Exactly.
that I think we
You
ought
know,
to
think
watch
about
for.
how you can use pieces of equipment in your facilities to parallel function. The fact that on certain pieces you reach, on other pieces you step like on stairs. I mean, just think of bus steps. Those are probably one of the biggest barriers to some of our older patients.
Absolutely.
You know, and working on, she's on a piece of equipment called a kinetron where she steps way up, similar to how she would be stepping on a bus.
Okay, good. Let's look at that tape
Okay.
then. Okay.
This is the toughie. Grab a hold, thumb up, straight up in the air. Let me know how that spot feels as we go. Ready, go. Straight up. Go. Way up. Way back. Go. Nice work all the way. Keep breathing. Counting on you to breathe. Keep that elbow straight, way back. Okay, and back down. Keep the elbow up and down. All the way down. Okay, I'm going to do the same thing with this as I did with the other one with the weights. You take a hold of this, and you're going to bring your hand down with the weight, and then bring your hand back with the weight. Way back. Keeping that thumb up. Lovely. down, and back. Now you do this at home, right?
Yeah.
And what do you do? What do you use for weights?
A pound of pinto beans.
Now, pound of pinto beans. Okay, let's see you do your shoulder rolls. Okay, back, good. Way around, good. That's it. Get that motion in there. Really get that left shoulder moving. That's it. Excellent. Way back. And then forward. Try and forward. Good. 1, 2, 3. Excellent. Excellent.
It's supposed to creak.
It's supposed to creak. Okay, and then let me see your stretch against the table. Put this leg back. Okay, put this leg back here. Good. Put it back. Keep the heel down and lean forward. That's it. So you feel the stretch. Ooh, keep this heel down just so you feel the stretch. Now you're feeling it now, I'm sure. Nice big steps. Good. Way up, way down. Good. Push, just like that.
That's
Okay.
pure creaking.
Now what I want you to do is try and get enough force that you can get up to the red needle. Push real hard. Come on, get up to that red needle. Good. Push hard. Push. Good. That's it. Go. Good work. That's it. Excellent. Excellent. All right, what I want you to do is I want you to grab a hold of the handles and just bring the handles around. There you go. That's it. And reach using your arm. That's it. Keep going and be sure to move your shoulders. That's it. Just like that. Keep going. Keep going. That's it. Now you're going to get this little black gauge to move, but just a little bit. Don't worry about it. That's it. Right up to there. Good. Keep going. That's it. Now try going the other direction. Come on backwards. That's it. That's it.
Ooh, that's harder.
You're using different muscles when you do it that direction, okay? What I want you to notice is the way it really gets her scapulas moving, okay? Not only is she getting some good reaching motions of her shoulder and some good repetitions, but she's getting some real good thoracic motion and some real good, rotation in through there, but some good scapular motion, the way she's bringing her scapulas back to get some good retraction.
Kara, how is that patient doing today in relation to her goals?
Oh, she's
And how
doing,
does she walk?
She's doing real well. She's not coming in anymore. She's walking beautifully. It was so funny. The very first time she came into the clinic, I noticed her walking down the street, and I really thought, this lady walks like a little old lady. She did. She kind of shuffled, and she was my patient that day. That was the very first time, and now she's doing beautifully. She rarely uses her cane. Except for long distances, and she's dusted that shelf that she's been wanting to dust. And
Wonderful.
She's doing a real nice job.
It's nice to hear success stories, it really is. Now, how do you measure a person's progress? We know about the functional ambulation profile, but how else do you?
Well, what I always do an initial evaluation. I always do a discharge eval. Another thing that I do is I actually monitor progress on a treatment basis, checking the person when they come in, checking them when they leave, so I can assess what they're doing at home. If they are in fact following through, they shouldn't have that much of a discrepancy, from the beginning of a treatment program to the end. I like to do that to make sure that there's some follow through.
And you share the information that you find with the
Definitely.
patient.
That helps out, especially if you have depressed patients. Like I said, this lady was depressed, and still is, but depressed patients have a real hard time realistically evaluating their progress.
Yes.
They may well tell you that they don't think they're doing any better. If you can show them quantitative information on how they're improving, that's very helpful. It's also helpful to you as a therapist, because if you continue to work with depressed patients, you're going to feel like you're not doing anything. And you have to feel good about what you're doing. There's some statistics that as high as 50% of the elderly are depressed, and that could lead you to burn out in your job. And it's important that you're motivated to see yourself doing a good job.
Absolutely.
So I always look at the numbers, to see how I'm improving, not just for them, but for me too.
Now, you've given us a sample of a home exercise program in this handbook, which I think is on page 23.
Let me get. I like to give this, and I mentioned before the adverse effects of just sitting for patients that need to get up and move around. Dr. Brocklehurst out of England says the British secret weapon is getting his patients up and standing once an hour. He said if they would simply do that, he said you'd see a tremendous decrease in the problems that you associate with old age. And what I do is, this is actually on the left-hand side are times.
Okay.
And I will give this to a patient. This isn't an exact copy of it, and the word is hypokinetics, not hyper. But
Sure.
it's all right. They'll have a grid where they can fill in and check each day when they stand up and they walk and then they shrug their shoulders. This was one of the ones I had done for a patient. And I'll have her do the various exercises at different times in the day, because classically a lot of my patients just sit at home and don't move. So this is an impetus to get them going, to get them to do something once an hour.
And at 12 noon, you see the word Coke bottle, and we'll explain that in just a couple of minutes. It's a little bit of a puzzle the first time you look at it, I think. But let's talk about motivating strategies. What if you think a patient may not follow up at home? How do you motivate people? That's so hard sometimes.
Yeah, no, I agree with you. In the first issue of Topics in Geriatric Rehab, we already plugged it, I'm not doing it again. Dr. Stadefalk did a beautiful job pulling together ways of motivating older persons, and he really didn't have much to go by except for the classes that he led. And on page 6 and page 7 are some of his ideas. And he talks about the fact that you need to fulfill the person's need. Make sure that it's safe and secure, that you're not asking them to do something crazy wild, or they may perceive as crazy and wild, and that it's something that hooks in with their identity, that you're not coming out there and trying to be Jane Fonda, which they may well not identify with, that it's stimulating for them, that it's not boring. And one real good technique is the behavioral contracting, and he mentions a couple different ways of doing that. One is listing positives and negatives, so the person can see what may well happen if something happens on a negative side.
If they don't exercise.
Exactly.
Yeah.
Or from the exercise itself. They may get fatigued. There's a chance that they may have some cardiovascular problems, but listing them all out in contrast to the positives. And then they make a wise decision based on positive and negatives. Then just simply having them list the positives and then sign the contract that they're going to try to exercise. There's also self-control techniques like monitoring, writing down what they do every day, similar to the checklist I showed you, and then ways of sustaining motivation. You could have rewards like T-shirts or certificates, or even the night nurse telling a patient that they did a nice job. In addition, on the other page are some differences on mechanistic versus humanistic approach to exercise, and I like that because our notes have to be mechanistic. We have to show quantitative differences. Yet if we want to get people to participate and really stick with an exercise program, we have to use a humanistic approach. We have to see what motivates them, how they can continue to do the program. And this is especially true if you're going to do a group, if you're going to work with a group exercise class.
So what this chart is showing us is how to translate the necessary mechanistic approach into the humanistic terms for expression to our patients. Okay. So you do find then that conducting classes is helpful with your patients rather than or in addition to an individual basis?
Definitely.
Or a home
it's
program?
nice. It provides socialness. It can fulfill a lot of needs that someone may have to get together with other people, or just to do exercises in a fun way. Sometimes it's real boring to do exercises by yourself.
Amen. Okay, what we're going to ask you to do now is show us some of the exercises that you use in the classes and that you have the patients practice at home.
Okay. We have a gentleman who volunteers at Harmerville who's going to help us, and it's Mr. McNulty. Good to see you. Have a seat. First, we're going to do the Coke bottle exercise. And what I'd like you to do is take hold of a Coke bottle.
Okay.
We've got to take off our shoes. And
empty the Coke bottle.
That's right. I like to use this exercise for people that sit at a desk. For example, if you sit at a desk or you sit in a chair and the person complains to you, my legs get really stiff. Whenever I get up to walk, my legs are stiff. What this does, and what you're going to do is you're just going to put your foot in the nice little groove of the Coke bottle and roll it back and forth. And you can use this while you're playing bridge, while you're sitting through a movie, while you're watching television, and you don't even have to think about it. And just roll the Coke bottle back and forth.
It's like a little massage.
Exactly, exactly. And it's just simply rolling it back and forth. And it's nice and easy. And that's all you got to do. There's not a lot involved, but it gets your muscles moving so that you're not getting some tightness in all the musculature and the soft tissue around the joint. Okay. All right, let's try another one.
Okay.
All right, let's put our shoes back on. And oops, let me find mine. What we're going to do is, and I'd like you all to do this with me. Stand up. You look a little bored.
And not just the studio audience. We want people around the
everybody,
country to do this.
come on.
We want Dubuque to stand up,
That's
and
right.
Los Angeles to stand up,
Definitely
and Boston
Los Angeles.
to stand up. Come on.
All right, what we're going to do, these are just some exercises you may want to do if you do a group, because they're kind of fun. Remember I mentioned that hips get tight, so we're going to do what I call hip clocks. All right, and we're going to pretend that we have a clock around us. All right, and the first thing we're going to do is we're going to go to 12, this is semi-obscene. We're going to do 12 o'clock, all right, then we're going to find 3 o'clock, way over there, that's it. 6 o'clock, all right, 9 o'clock, and then back to 12 o'clock. Now, I let you do it easy that time. Shoulders should not move. All right, that makes it very different. If you find the person in front of you going way over to one side or the other, tap them on the shoulder, say hips, just the hips. All right, so let's try it. I'm going to go around the clock. We're going to do 12, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12. Let's do it backwards. 12, 11, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Excellent.
We don't have a chance to stretch during these video conferences very often. That feels nice.
Now we're going to do some reaching for our arms. So let's go straight up in the air and reach as high as you can, and reach your right arm over your left arm over your right. Then I want you to turn to your left. All right, everybody turn to your left. Put your hand on the person's shoulder in front of you and rub. There you go.
Nice.
Doesn't that feel good? All right, then let's turn the other way and say thank you to the person who did it for us. You're tight over there. All right, now we'll try, since I always mention posture and how to get the shoulders moving and the head in a good place, so we'll stay to the side a little bit. And what I want you to do, because you might hit the person next to you, is pretend you have a piece of chalk right in your shoulder, and you have a chalkboard right next to you. And you're going to draw circles on that chalkboard with your shoulder. So let's draw the circles this direction, way around. There you go. You can move your shoulder. That's it. Move it way around. Okay, then let's go back the other direction. Good. Make nice big circles. Now make little circles. There you go. Okay, now let's try something for our neck. And I call this the turtle exercise. And what you're going to do is you're going to stick your head way forward and then way back. So you're going to do a chin tuck. So forward and back. Oh, what great turtles. All right, sit down. Let's have you sit down. I got one more for you. And this is my favorite. This one I call yes, 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 no, 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 maybe, maybe, maybe. All right? And it's just like what it sounds. So we're going to do it together. Real slow. Yes, 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 no, 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 and maybe, maybe, maybe. And that's it.
Well, that's very refreshing.
Isn't that
really
nice?
Feels good. Yeah, and thank you. I understand that you are 80 years old and volunteering out at Harmerville. Right. So thank you so much for being willing to come and show us how fit a gentleman of 80 can be. And thanks for those exercises.
Oh, sure.
Those are really...
They're fun.
So just a few times every day, and
sure.
we can all benefit from them.
And it's something that you'll remember to do at home when you start to get stiff.
Yeah, absolutely. Can you tell us quickly wherever you got these Coke bottles? Those are not easy to find these days.
My favorite story. It's kind of the definition of chutzpah. Do you know what chutzpah is? Chutzpah is like if you kill your parents and then you throw yourself on the mercy of the court for being an orphan. That's chutzpah. All right, well, I looked for these Coke bottles and I couldn't find them anywhere, so I called the vice president of Coca-Cola and I told him I have this exercise I want to do, but you can only do it with Coke bottles because they have that little gully in there. Anyway, he said, look, he says, I have arthritis in my knee. He said, send me the exercise if it helps. He said, I'll send you a case. A month and a half later, we got 6 cases of Coca-Cola. Worked out great.
Exercise goes better with
That's
Coca-Cola.
Right. What an advertisement.
Okay. We have just a minute left before we open the phones for questions from the audience for you and for Dr. Lee. Anything you'd like to add?
Well, I think what I'd like to do is reinforce what Dr. Lee said about prevention and how important it is, especially in the area of exercising. And I didn't get to allude to it, but on page 10 there are some effects of not exercising that I think are important to know. And Dr. Robert Butler, he used to be the head of the National Institute on Aging, said it the best on the cover of the Age page. He said, if exercise could be packed into a pill, it would be the single most widely prescribed medication in the nation. And I think as physical therapists, as rehab professionals, we're the ones that are out there prescribing exercise, and we should really try to instill that in our patients. The other thing I'd like to say is that as a physical therapist and as rehab professionals, we have to keep an eye out when we work with the older person. The statement, the eye cannot see what the mind does not know, is real important, and we have to always keep open what could be the main problem in working with our patients.
Because it's not always the obvious.
Yeah, definitely.
This concludes the clinical update presentation of physical therapy and the geriatric patient, which featured Dr. Carol Bernstein-Lewis. For more information about clinical update or any of Aaron's educational programs, call or write the American Rehabilitation Educational Network.